So before
Yeah.
starting the presentation proper, I invite you all to watch this short video.
I feel that my life is a perfect example.
The man behind me hasn't been able to breathe on his own since 1952, but that hasn't stopped him from living a great life.
Sorry, this.
Okay, go ahead.
Paul Alexander was one of the last people in the world still in an iron lung. It was home, keeping him alive more than 70 years. In 1952, Paul contracted polio and became paralyzed from the neck down. He was 6 years old. Eventually, Paul would be able to gulp or take in air for hours at a time, allowing him to leave the confines of the iron lung during the day and accomplish more than anyone thought was possible for him. College, law school, and a 30-year career as a courtroom attorney. And Paul wrote his autobiography.
I've got some big dreams. I'm not going to try to accept from anybody their limitations on my life. I'm not going to do it. My life is incredible. Polio is a horrible disease. I cannot move, period. Well, a lot of humanity does not.
All right. All right, so that is Paul Alexander, so who lived most of his life inside an iron lung. The aim of his, being in an iron lung was just to breathe. But today we have more challenges. So we have more sophisticated ventilators, which are precise and powerful, but which can be potentially harmful as well. So every breath we deliver through a ventilator can be save the life, or it can injure the lung. So we have to be clear of what we want at the end of the day. So during next one or so I'm going to cover a few things that would be beneficial, to have an idea regarding the ventilation. So I'll be discussing the basic principles of mechanical ventilation, setting up a ventilator, which is the core topic today, and we'll see how we can apply those things into case practical scenarios, as well as how we tackle the problems when we encounter problems during ventilation, and a little bit of loops and scalars. All right, so talking about the core goals of mechanical ventilation, what we want. So one thing we need to ensure adequate ventilation, as adequate oxygenation, as well as to facilitate carbon dioxide elimination, and most importantly, to protect the lung from further injury. So our aim is not to normalize the blood gases, but to keep the lung open and safe until the underlying condition heals, like in pneumonia patient. Until the pneumonia settles, we have to make sure that all the strategies to keep the lung safe. So this is achieved by lung protective ventilation, which is a game changer in critical care settings. Why we need a lung protective ventilation? Because ventilator can do damage. So ventilator induced lung injury.
Mihran, we can't hear you. Mihran, can you hear us?
Sir, 5:30 Telanganamada. 5:30 Telanganamada badminton.
A polite request from the participants. Could you please keep your mics muted? Mihran, can you hear us? We can't hear you actually. And your screen is, I think it has freezed. No. There's a problem from Mihran's side. Just hold on for a second. I have informed him. He will sort it. Mihran, still we can't hear you. Can you hear us?
Now can you hear me?
So, yeah.
All right.
Thank you. Right. Now we can hear you.
All right. So I think can you see the sides screen?
We can see now. Yeah, we can see now.
All right. So I was discussing about the ventilator-induced lung injury. So basically, apart from the volutrauma, biotrauma, atelectrauma, and barotrauma, oxygen per se can cause harm. So it can cause oxygen-induced free radical formation as well as absorption atelectasis. So we have to prevent these ventilator-induced lung injury. So how can we prevent those? Basically, we have to stick into few rules, few strategies. Not rocket science, just low tidal volume ventilation, 4 to 8 millimeter per kg predicted body weight, plateau pressure less than 30, drive-in pressure less than 50, and the PEEP should be individualized. So it should be compatible with the pressures and compatible with the lung compliance and oxygenation and as well as the hemodynamics. So we have to adjust the things accordingly. All right. So regarding the low tidal volume ventilation, so it is mainly came into the arena in year 2000 with the landmark trial, ARMA study, so which has shown the clear survival benefits with low tidal volume with ARDS patient. So which is one of the most impactful intervention in critical care settings, all right? So which will prevent the volume trauma and induce biotrauma. So over last 2 decades, which has been shown, proven over and over again, this low tidal volume ventilation, it has mortality benefit. All right. Okay. So let's move on to lung physiology a little bit. So imagine if you blow a balloon with a straw. So you have to overcome the resistance of the straw as well as the elastic work of the balloon. So same applies to the lung as well. So either patient or the ventilator have to overcome the airway resistance as well as the elastic work of the lung. So when we increase the transpulmonary pressure, the lung volume increases. All right. But we have to overcome the resistance as well. Due to resistance, during inspiration, it goes like that. So the work of breathing, when you talk about work of breathing, so it has both resistive work as well as the elastic work, which is denoted by this triangle. So what happens when in non-compliant lung diseases like ARDS, pneumonia, pulmonary edema? So those are, the lung is non-compliant, so it needs more pressure to achieve the same volume. So the graph is less steeper, but so increase in the work of breathing, but the resistive work is same. So, but what happens during obstructive lung disease, the compliance is okay, but the resistive work will be more. So it needs more work compared to the compared to ARDS and things. And you can see the expiration is inside the elastic work because it is passive process. So, but in severe obstructive lung disease, even the expiration can be active. So this elastic, resistive work can go beyond the elastic work during expiration as well. So when we incorporate this into a pressure time curve during the inspiratory phase, which has achieved pressure, which is called peak inflation pressure. So this peak inflation pressure determined by the 2 things. One thing is the airway resistance as well as the lung compliance. So, and the flow ceases during the inspirated force, and during that period, the pressure is called plateau pressure when there is no flow. All right. So in obstructive lung disease, what happens is the resistance is more, hence the peak inflation pressure is more. But since the compliance is normal, the plateau pressure is normal because plateau pressure is solely determined by the compliance. All right. So, but in ARDS patient like non-compliant lung disease, both the plateau pressure and peak inflation pressure rises. So you can clearly see the plateau pressure rises. So eventually, the key message is peak inflation pressure doesn't reflect the barotrauma risk. It is what ventilator sees. But the plateau pressure is solely determined the compliance, and it is the pressure what alveolar feels. Hence, it is closely related with the barotrauma. So you have to clearly understand that fact. Okay, so keep those things in mind. So we go on to the plateau pressure. So they have clearly shown if we maintain a plateau pressure less than 30, so the barotrauma is less. All right, as well as the driving pressure. So that driving pressure means the pressure difference between pressure support and the PEEP we maintain. So if we maintain a driving pressure less than 15, again the barotrauma risk will be less. So they have clearly shown lower the driving pressure, lower the mortality. All right. I think you understand the fact. Then we come into the PEEP. So I said PEEP should be individualized, depending on several factors. So let's see what happens when we increase the PEEP. So initially, it reduces the component of the collapsed lung. It gradually recruits the lung. At the same time, part of the lung is going to distend, and eventually it is get over distended. And the compliance will gradually increase and come into a plateau and later come down. So you can see this part of the graph shows the over distended lung. So that is not preferable to ventilate. And this part, it has more collapsed lung. It can cause more atelectroma. So hence, the more, mainly in ARDS patient and uncompliant lung disease, we have to maintain PEEP between this. That is moderate PEEP. So 8 to 14 line. All right. So this is bit different in obstructive lung disease and neuroprotective ventilation. I'll discuss it later. All right. All right. So I don't think these are new things to you. These low tidal volumes, low pressures. The problem with us, not with us, most clinicians in the world, we know the facts, but we don't apply. So, so 1/3 of the patient, still being ventilated with large volumes and over pressures. So this is the problem is with the is not with the knowledge, but with the execution. All right. So that is a bit more theoretical stuff. So we'll move on to the bit mechanical stuff, keeping those physiological stuff and evidences aside. All right. So this is invasive mechanical ventilation. So I'm going to discuss more invasive mechanical ventilation. I'm not going to touch the non-invasive ventilation here. All right. So before talking about invasive mechanical ventilation, we have to know about a ventilator breath. So in a breath, even if a spontaneous breath or a ventilator breath, it has two components. One thing is one component is inspiratory phase and the expiratory phase. All right. So if we take an inspiratory phase, that has three things. So one thing which has to trigger the breath. So it can be machine triggered or patient triggered, basically. So machine triggered. So for an example, if we set if in a paralyzed patient, if you ventilate in a paralyzed patient, if we set a ventilator rate of 20, they have respiratory cycle will be 3 seconds, and every 3 seconds they initiated a breath. So there's no need of patient trigger. But if the patient breathes on the ventilator, that negative pressure or flow, flow change can be detected by the machine and trigger that can induce a breath. All right, that is trigger. And once the breath is triggered, then the next step is what is controlled during the inspiratory phase and what's the limit. So in pressure control ventilation, it can be pressure, or volume control ventilation, it can be flow achieving a set tidal volume. All right. So next thing is cycle. What ends the expiratory? What ends the inspiration? Okay, that can be time or flow in volume control pressure control ventilation, or even volume or pressure, even pressure and volume. All right. So depending on these factors, we can identify four types of breaths. All right. So first thing is the mandatory breath. So in mandatory breath, there is no patient trigger. So all this that is triggered by the machine and ended by the machine. So during the inspiratory breath, that is fully supported by the ventilator. All right. So in assisted breathing, the breath is triggered by the patient. All right. But it is fully supported by the machine. All right. and ends by the machine. Okay, that is assisted breaths. And you can see the spontaneous breaths that is not supported, which has inspirated phase and the expirated phase. And the supported breath. So these spontaneous breaths are supported by the pressure support we have given. So breaths are triggered by the patient and partially supported by the machine, what we have set as a pressure support, and ended by the patient, which is called supported breaths. Those are the 4 breaths we can identify. All right. So then we talk about the control variables. All right. So we talk about the factors, the main thing which is controlled during the inspiratory phase. That can be pressure control, volume control, or even it can be dual control, like pressure regulated volume control, low volume targeted pressure control, likewise. All right. So 2 main entities, mainly the volume control ventilation, where we set a definite tidal volume. All right. So ventilator delivers a constant flow to achieve that set tidal volume. All right. So expiratory phase, the flow expiratory phase is passive anyway. So it achieves certain peak inflation pressure or plateau pressure. This pressure is depends on the lung compliance. So the less compliant lungs have higher inflation pressures, while the more compliant lung has lower pressures. All right. So this volume control ventilation is more in favor of using conditions where we need a precise minute ventilation. All right, like in neuroprotective ventilation or ventilating metabolic diseases like metabolic acidosis. But the problem is, as I said, the pressures can go up and cause barotrauma. All right. In contrast, in pressure controlled ventilation, we set the constant pressure, and ventilator delivers a constant pressure during the inspiration. So volume gradually increases, and the volume achieved is depends on the lung compliance again. So less compliant lung diseases like ARDS achieve less volume, and flow is decelerating and come into expiratory phase. So this is due to this limitation of the peak pressures as well as decelerating flow. This pressure controlled ventilation is in more favor of ventilating non-compliant lung diseases like ARDS. But the problem is the tidal volume can be varied, so we have to keep an eye on the tidal volumes, okay, depending on the compliance. All right. But what evidence says, so no matter the we discuss things, so they haven't demonstrated any mortality difference between these two, volume control or pressure control ventilation, as far as we maintain those lung protective strategies. So again, I have to emphasize, we have to, whatever the mode, we have to maintain those lung protective strategies. All right. So coming into the main part of the lecture, how to set the ventilator up. Okay. So we have to set certain things. We have to set the mode. We have to set the FiO2, tidal volume, respiratory rate, I ratio, PEEP, and even trigger sensitivity, and few more. So the basic stuffs are these. All right. So let's talk about one by one. Okay. So how to set the FiO2? Okay. So our goal is to maintain adequate oxygenation, not hypoxia, not hyperoxia. Both will be harmful. So anyway, in initial stages, we should start high. We should start with high 100% oxygen. Then we assess the oxygenation by oxygen indices like partial pressure of the oxygenation, saturation, and even PEF ratio. And depending on those parameters, we can adjust the things. So in most of the ICU patient, the target is to maintain 90 to 96 saturation and 60 to 80 millimeter mercury of partial pressure of oxygen. All right. But in ARDS patient, the saturation targets are lower. It's 88 to 95. It is because we are not going to chase oxygenation in the expense of barotrauma or volume trauma. One thing, as well as with hyperoxia, this insult can be worsened. I mean, that can cause free radical induced lung injury. Therefore, in ARDS patient, we maintain 88 to 95 saturation, 55 to 80 millimeter mercury of partial pressure of oxygen. And in, as you all know, the chronic hypercapnic patient, like in severe COPD, the oxygen targets are lower, 88 to 92. And in post-cardiac arrest patient and neuroprotective ventilation, we aim for a bit higher targets to minimize the secondary brain injury. That would be 94 to 98 like. All right. So, and other thing is, you have to always combine this FiO2 with PEEP. So for an example, if when we ventilate an ARDS patient, when the patient desaturates, no point of keep on increasing the FiO2. So, I mean, we have to increase the PEEP accordingly as well, because we have to ensure that both things should be in a balance. All right. So you can use the graphs, tables which has provided by the ARDS net, and other things which can set a optimal PEEP. And the other important thing is you have to reassess frequently and titrate the oxygenation to match those set the oxygenation targets. So next thing is the tidal volume. So as I have been telling over and over again, we have to maintain low tidal volume. So important thing is we have to adjust it to the predicted body weight, because the lung volume is determined more with the height, not the weight. All right. So suppose you have a patient with 150 centimeter patient with 100 kilos. So you are not going to ventilate 600 ml of tidal volume. Rather, you have to calculate the predicted body weight for 150 centimeter and calculate accordingly. So in ARDS patient, you may start with 6 ml per kg, and in other patients, you can start with 6 to 8 ml per kg. And then you have to assess the pressures and titrate accordingly. All right. Say it is the plateau pressure is more than 30. What you have to do, you have to reduce the tidal volume by 1 ml per kg at a time. Then reassess. Still, if it is still high, you have to go down with the ventilator up to 4 ml per kg. All right. So this is the basis of low tidal volume ventilation. All right. Then the respiratory rate. Okay. So we have to adjust the respiratory rate along with the IE ratio. Okay. So regarding the respiratory ratio, we should set the respiratory rate of 12 to 20. But keep in mind, most of the patient we start to ventilate has high respiratory drive. Originally they have, before intubation, they have higher respiratory rate like 35, 36 like that. So we have to make sure we can't just convert them to 35 respiratory rate into 12. All right. So that in those patients, we can start with a higher respiratory rate like 20, 24. Then we can assess the carbon dioxide status and the ventilation and adjust the respiratory rate accordingly. So in ARDS patient, what happens? So we start with high respiratory rate like 20, 24. And suppose if the carbon dioxide is high. So again, one major thing I have to emphasize in ARDS patient, we accept permissive hypercapnia. All right. What do you mean by permissive hypercapnia is we can accept high carbon dioxide level, which can be 55 or 60. There is no defined value. but we have to go with the pH. So if the pH is less than 7.2, then we have to increase the respiratory rate, okay, up to 35, okay. So I ratio in non-compliant lung diseases, we said is 1 to 2 usually, but in extreme cases, we concentrate more on oxygenation, where we can set the I ratio 1 to 1 or even inverse ratio 2 to 1 or 3 to 1 to increase the inspiratory time. So there our aim is to improve the oxygenation, but those things have no evidences for high ratios or inverse ratios, but you can consider those things in refractory cases. In COPD or obstructive lung disease patient, our main problem is the exhalation. So we have to ensure we give adequate time for the exhalation. So otherwise there will be air trapping and causing dynamic hyperinflation and autopsy development. So what we can do is, one thing is we can start with lower respiratory rate, which will ensure adequate inspiratory time and adequate expiratory time, as well as we can use lower IE ratios. Suppose we have been ventilating with 20 respiratory rate. So then the with I ratio of 1 to 2, the respiratory cycle will be 3 seconds and the expiratory time will be 2 seconds. So, and we reduce the respiratory rate to 12. What happens? The respiratory cycle is 5 seconds now, and expiratory time will be around 3 to 3.5 seconds. So that would benefit, that will lengthen the expiratory time. As well as if we reduce the I ratio as well, that will increase the expiratory time. So, but you have to keep in mind, once we increase the expiratory time, so the flow need is more because they need more higher flow rates to achieve this tidal volume with this time. All right, but the respiratory cycle would be completed during that given expiratory time. That is obstructive lung disease. In metabolic acidosis like condition, eventually we need, we need higher respiratory rate to match the respiratory compensation. Otherwise, there will be a mixed acidosis until this metabolic condition is sorted out. All right. For an example, DK patient, we need, initial setup would be respiratory rate of 24, 26 like that, and we gradually reduce according to the control. Okay. All right. Then the PEEP. So again, I have said already. So we have to ventilate in this part of the ventilator curve, not over the distended part, not the collapsed part. So that first in non-compliant lung diseases, we can set the moderate PEEP, maybe above 5 definitely, and titrate the PEEP physiologically. So we have to see, as I said, the plateau pressures, driving pressures, and the lung compliance, and the hemodynamics as well. So, but in obstructive lung disease, what happens if we give a higher PEEP? So that will add on to the auto PEEP if there's any, and can increase the barotrauma risk and the hemodynamic instability. As well as in neuroprotective ventilation, the PEEP we apply, if we apply a higher PEEP, what happens? That can transmit to the cerebral circulation, can cause increase in intracranial pressure, as well as it might impair the hemodynamics and cause impaired cerebral perfusion pressure. So we have to ensure the PEEP should be individualized. So anyway, any of the patient, we should avoid higher PEEP, that means above 16 or so, and aggressive recruitment. Okay. All right. I think up to now it's clear. So if you have any question, you can ask at the end of the lecture. All right. let's move on to the next part. The modes of the ventilation. So we have conventional modes and advanced mode. Conventional mode, what we use, it's an open loop, open loop control. So what we say, ventilator delivers, ventilator doesn't think about the patient. Whatever happens in the patient, they have no sense, basically. So like in control mandatory ventilation, assist control ventilation, and famous SIME or pressure support ventilation. But in advanced mode, they use closed loop control. So they take information from the patient, the pressures, even oxygenation, the compliance, and accordingly they adjust their output. So it's sort of a feedback mechanism. So those are, more preferable in ventilating patient in terms of synchronization, as well as minimizing the risk of patient self-inflicted lung injuries. All right. So let's talk about the ventilator modes in simple. All right. Control mandatory ventilation. So this has control mandatory ventilation as all the breaths are mandatory breaths. So it is fully machine triggered and fully machine cycled, like we ventilating a paralyzed patient. So no patient efforts are not entertained and all. So if there's patient effort, there may be a asynchrony or dysynchrony. All right. So this is beneficial in conditions like where we need precise minute ventilation. Like in neuroprotective ventilation, as I said, we have to keep the carbon dioxide level in a narrow margin, precise settings. As well as in severe ARDS patient, early stages, they have high respiratory drive. So what we do is we paralyze the patient initially to achieve a better control, and continue mandatory ventilation. And of course, during intraoperative ventilation, we usually use this control mandatory ventilation as the patient are paralyzed. All right. The problem is this needs deep sedation or even paralysis. So we can't keep on continuing this control mandatory ventilation because that sedation as well as paralysis has adverse effects like hypotension or iso-acquired weakness like that. So we have to shift quickly from this full control ventilation to patient-triggered ventilation as quick as possible. Then the assist control ventilation. Here, the patient breaths are entertained. So patient can trigger breaths, but all the breaths are supported. So this will deliver a guaranteed minute ventilation. And this is more beneficial in acute respiratory failures where we need full support. But the problem is this can cause hyperventilation and respiratory alkalosis, and this can cause patient ventilator asynchrony as well. All right. So this is assist control ventilation. So this is SIME or synchronized intermittent mandatory ventilation. So arguably this is maybe the most popular mode among you. All right. So this combine three breaths actually. This combine mandatory breaths and spontaneous breaths. So this has three types of breath. It has mandatory breaths, and if the patient breathes during this trigger window, it is delivered as assisted breath. So which means fully supported. And if the patient breathes out of this window, it delivered as a supported breath by a pressure support we said. All right. This is historically used as a weaning mode. So transition from a fully controlled ventilation to the spontaneous mode. But in modern practice, we use this SIME for patient who has the spontaneous respiratory drive. So which needs less sedation, as well as it allows patient spontaneous breathing and maintain diaphragmatic activity, and which is a good transition mode for recovering a patient. But the problem is, since the patient respiratory rate can't be is unpredictable, this won't be delivering a predictable minute ventilation. So we have to make sure the minute ventilation is delivered or not, as well as there may be lots of asynchrony between the patient and the ventilator. All right. So these are the challenges during SIME. And the pressure support ventilation. So this is as you know, this is the spontaneous mode. All right. So where we set a patient is spontaneous breathing, where we set a pressure support. Okay. So so this is basically a weaning mode. Patient should have enough respiratory drive, and all the breaths are supported. And once the patient, we can wean off the to a lower pressure support, we can extubate the patient. So, I mean, this is reduce the work of breathing and the sedation requirement, and ensure and preserve the diaphragmatic activity and improve the patient comfort and the synchrony. So this is basically weaning mode. So the problem is this: if the patient stops breathing for a while, so we can't, I mean, there will be a problem that can cause hypoventilation basically. So we have to set a backup mode as, I mean, always we have to set up a backup mode. All right. It's the pressure support ventilation for spontaneous mode. Okay. Let's talk about a bit of advanced mode. So advanced mode, as I said, it has a better closed loop control. So therefore, those modes have better control. So APRV is one of these days it is used frequently, especially in ARDS patients. So this APRV, or airway pressure release ventilation mode, uses 2 levels of CPAP basically. So patients should have ideally spontaneously breathing. So the pressure high, so is, I mean, maintained for a long, for the inspiratory time, and patient can breathe on that CPAP like that. The concept is the open lung concept. The lung is kept open for a longer period to ensure a better surface area for oxygenation, as well as it will eventually reduce the atelectroma as well. And for a brief period, it drops the blood pressure to a pressure low, in which the exhalation occurs. Okay, but this APRV is not recommended for the patient who has profound shock, because the intrathoracic pressure will be high. That can worsen the shock, as well as it is not preferable for the patient who doesn't have spontaneous breathing, because in both stages, patient should have spontaneous breathing. That is more, I mean, that is ideal for this mode. So other things I'm not going to discuss. So if you have any questions, you can ask. So pressure regulated volume control, where the pressure is regulated in each breath to achieve the set volume, tidal volume, and proportional assist ventilation and neurally adjusted ventilatory assist. So that again, we assess the ventilator assess the patient effort by taking the electric signals and deliver the customized breaths to the patient. Okay, so that the patient synchrony will be better and low risk of trauma. All right, to summarize the thing, for the mode selection, so ARDS, we can use either mode, volume control or pressure control, provided that we maintain the lung protective ventilation. COPD patient, we can use volume control or even pressure control. The aim is to give adequate expiratory time to avoid dynamic hyperinflation and auto-PEEP. Neuroprotective ventilation, volume control is preferred, to maintain stable carbon dioxide level and prevent to ICP rise. Post-op patient, we need more pressure control, pressure support ventilation, or SIME, or even newer mode like PSV or NAVA to ensure patient comfort and the early mobilization and early weaning off from the ventilator. All right. So I think up to now, you know something. All right. So let's apply this into a practical scenarios. All right. Case 1. We have a patient with severe pneumonia. It's a 54 years old male. And now he has features of severe ARDS. He is in a type 2 respiratory failure and hence who needed intubation and transfer to the ICU. X-ray shows bilateral shadows and ABG shows severe hypoxemia with PF ratio of 52 and slight mild hypercapnia and while maintaining the pH of 7.2. All right. So what's your strategy? So what what's our main goals? So maintain the lung protective ventilation, right? Let's see. So in ARDS patient, we have to provide low tide. We can use either mode, volume control or pressure control. We should start with low tidal volumes. Wait, this is the Hamilton simulator. Simulator. So we usually have Hamilton C6. So and some of the centers has C6 as well. We'll use the C6 one. All right. So first we have to set the patient details. So he's a male patient. Predicted height is 170. So the predicted weight is 66. Then we'll select the mode. So we can select either mode, either volume control or pressure control, which should be assisted control, not the SIME initially. All right. So I'll, for a reason, I'll check, set the volume control ventilation first and confirm. And this is severe hypoxemia. So we should start with high, 100% oxygen. PEEP, ARDS patient, to match the 100% oxygen, at least we have to set 10. All right. And tidal volume should be low tidal volumes. Weight is 66, predicted body weight. So we can set it 360 or 370. Let's see, 370. Set. So he has been breathing with high respiratory rate. So this can't be 12. So at least with 20 to 24 like that. So always remember, when we adjust the respiratory rate, we have to adjust the inspiratory time to set the IV ratio, desired IC ratio. Here I would set the I ratio of 1 to 2. This thing, this is better flow pattern, so I use the conventional one. Flow trigger, this is the default value. So, and we confirm the patient things, and we'll start the ventilation. So let's see what happens. All right. So we have set the tidal volume. So it delivers 353, likewise 370 tidal volume, and see the plateau pressure. See the peak pressure. We'll increase the tidal volume and see what happens. So volume control ventilation, as you can see, it increase the pressures and come to peak inflation pressure, and the flow is maintain the constant flow since this is a volume control ventilation. All right. So here the peak pressure is 31. So then we have to check the plateau pressure. How to check the plateau pressure? That is one of the things you have to know. So what you have to do is you have to do a inspiratory hold. So you do an inspiratory hold for at least 3 to 5 seconds and stop. And there you can check the plateau pressure. Here it is the 24. This is the peak pressure that is not equal to the plateau pressure. So plateau pressure is not, usually it's not monitored. So we have to do the inspiratory hold and measure it, by ourselves. Okay. Now if the plateau pressure is less than 24, so that is acceptable. Suppose it is more than 30, we should reduce the tidal volume to reduce the tidal, to maintain the plateau pressure less than 30. Okay, so here the driving pressure is, plateau pressure is 19, PEEP is 10, so the driving pressure is around 9. That is acceptable. So which is less than 30. So saturation is 92. So we can come down with the oxygenation little bit, maintaining 88 to 93. And if the carbon dioxide levels goes up and pH is less than 7.2, we can increase the respiratory rate up to 35 and adjust the I ratio. So here, if the oxygenation gets worse, we can use the lower I ratio as well, like 1:1. All right, that is a rescue method. Okay, this is how we ventilate the ARDS patient. All right, so these are the key concepts. So low tidal volume, respiratory rate, targeting permissive hypercapnia. So PEEP, moderate PEEP, and target saturation would be 88 to 95. So failing these strategies, or failing these ventilator strategies, we can, simultaneously we can continue the other non-ventilated strategies as well, like prompt positioning, short-term neuromuscular blockage, or restrictive fluid strategies, or even early ECMO. All right. All right. So case number 2, a female patient, non-bronchial asthma patient, presented with features of near-fatal asthma. Now she is in type 2 respiratory failure. Okay, failing the conventional oxygen therapy, they decided to intubate the patient because there was impending respiratory arrest. Chest X-ray shows hyperinflated lung, no pneumothorax, no features of infections. ABG shows hypoxemia and hypopnea, suggesting type 2 respiratory failure. So how to ventilate this patient? So here, in obstructive lung disease, our main goal is to maintain oxygenation and to eliminate carbon dioxide without causing air trap. All right. So what we're going to do is so this is a female patient. Height is 160 and predicted body weight has predicted body weight around 450. And we'll select a mode. So we select a pressure control mode. And it's a severe hypoxemia. We'll set 100% again. And here the PEEP, which should be less than 5. Usually we use lower PEEP because it can, the extensive PEEP we add can be harmful. All right. So we set a PEEP of 3 like that. And the pressure control will make it 12 to, we'll check the tidal volumes and we'll readjust. And respiratory rate should be low because to ensure adequate expiratory time, we'll set it 12. And this I ratio, inspiratory time should be less to make sure the I ratio around 1 to 3, like. So let's make it 1 to 1 and see what happens. All right, so we'll start ventilation and see the flow volume curve. So it achieves a tidal volume of 360. So our target volume is maybe 6 to 8 liters per minute. This is acceptable. So we can, if the 450 is a bit high, so we can reduce the pressure support, pressure control to achieve a low tidal volume and see the flow volume. So we'll increase the respiratory rate a little bit and see what happens. So here you can see the graph doesn't come to the baseline. So there will be a AR trap. So that we have to reduce the respiratory rate to ensure adequate expiratory time. So always make sure the I ratio also should be adjusted whenever you change the respiratory rate. So we'll make it 1 to 3 and see. So here, how to check whether there's an auto PEEP. So there you have to check the expiratory hold. So you do the expiratory hold. We'll make it volume control ventilation. So you do the expiratory hold and check the total PEEP. This is the total PEEP, which is 3.6, and this is the extensive PEEP we have applied. The total PEEP. So the auto PEEP is total PEEP minus extensive PEEP, which is around 0.6. That is acceptable. We should keep the auto PEEP less than 5. All right. So if there's a dynamic hyperinflation, this auto PEEP will keep on rising. All right. So there. So what we have to do is we have to adhere to the measures where reduce the rate and allow more time for the expiration. So if the patient deteriorates in obstructive lung disease, suppose if the patient develops hypotension, so you have to hello. You have to exclude dynamic hyperinflation. Yeah. And if there's high peak inflation pressure, you have to exclude bronchospasm and tube obstruction like that. So as a rescue method, if you suspect dynamic hyperinflation, you can just disconnect the patient to allow the patient exhalation. All right. So next case is a traumatic brain injury patient, young chap, following RTA, having low GCS, no other injuries, and he has the features of Cushing reflex and suggestive of increased intracranial pressure. And he was intubated for neuroprotection as well as to control the neuroprotective ventilation. So pH ABG shows hypercapnia with adequate oxygenation. So here our aims are to maintain the neuroprotective targets. So the mode is in neuroprotective ventilation, volume control ventilation, and we set a 100% oxygen and titrate later. PEEP is should be low to moderate to ensure proper venous drainage. Adequate tidal volume, so maybe 360 according to predicted body weight, and respiratory rate adjust accordingly. Okay. So there you have to check the carbon dioxide levels frequently, and adjust the carbon respiratory rate to match the match the normocapian. So main thing in neuroprotective ventilation, we have to ensure normoxia, normocarbia, and normotension, apart from the normoglycemia and normothermia and things. So to achieve normoxia, we should adjust the FiO2 and P accordingly, and precise respiratory rate adjustment to achieve the tight carbon dioxide control, and ventilator strategies to maintain minimum effect of hemodynamics to maintain cerebral perfusion pressure. But in refractory cases, refractory high IECP cases, we can temporarily use hyperventilation targeting carbon dioxide level of 30 to 35. That is a rescue method. All right. So target saturation would be 94 to 98. All right. So that is how we ventilate patient, and that is how we apply things, our practical knowledge, our theoretical knowledge to practical cases. Then the next thing is the problem challenges we have. So however we set the numbers, there will be challenges. So patient ventilators asynchrony, or patient fighting with the ventilator, is one of the common challenges we have. That is basically due to the mismatch between the patient demand and what the ventilator delivers. So why it is problematic? Because it can cause patient discomfort, and it will increase the work of breathing, and eventually it will induce patient self-inflicted lung injury. That is a concept, that is described by the high respiratory drive can cause lung injury. That is called patient self-inflicted lung injury. So eventually that will increase the number of ventilator days, and number of ICU days, and the overall morbidity and mortality. So if I classify the things, that this asynchrony can be trigger asynchrony, or that can be a problem due to flow and cycling things. So I'll be discussing few common asynchronies. One thing is the ineffective triggering. So what happens is patient has an effect, but it is not detected by the ventilator, hence there is no ventilator beds. This can happen due to few reasons. One thing is, if the effect is less, if the patient doesn't have enough drive, or patient is deeply sedated, so this effect is not triggered, doesn't reach to the trigger threshold. Or else, if we set the trigger sensitivity is too low, suppose the patient generates a negative pressure of 2, but we have set a threshold trigger threshold negative 5 centimeter water, then it doesn't reach the 5, it doesn't trigger the ventilator beds. Or else this can be commonly seen in patient with obstructive lung disease who has auto PEEP. So what happens is, suppose if patient has auto PEEP of 8 and the trigger threshold is 2, the patient has to generate 10 negative pressure to trigger that ventilator beds. So what we can do, we have to basically fix this problem. Right? We have to identify, and we have to fix the problem. So for the auto PEEP thing, we know the things now. So we have to adjust the ventilation accordingly to avoid auto PEEP. And we can increase the sensitivity. We can come up with the negative pressure 5 to 2. Then it will trigger. Or else we can change this pressure trigger to flow trigger, because the flow trigger is more sensitive than the pressure trigger. That is why we commonly use flow trigger compared to pressure trigger. As well as it detects the flow. It doesn't need a higher pressure drop to trigger a breath. As well as we can reduce the sedation and improve the muscle relaxation to to improve the patient effort. So this is called ineffective triggering and how to fix that. All right. So next thing is the opposite thing, auto triggering. Patient doesn't have a trigger, but machine deliver a breath. So this is usually due to the few things again. So if there's a continuous flow despite of the patient stop the breathing, like in circuit leak, that flow will be detected by the ventilator falsely and trigger a breath. All right. So, or else if there's a flow disturbances due to the water condensation and the water in the tubes, this flow turbulence can detected by the flow sensor and cause it auto triggering. Other thing is when the patient has cardiac oscillation, especially in high cardiac output status, so there the cardiac oscillation can be misinterpreted as a respiratory effect and cause a ventilated breath. Also, if we set a lower, higher sensitivity level, for an example, if we set a flow sensor flow trigger to 1 liter per minute, even with a tiny slightest flow changes, that will induce a ventilator breath. So to fix that, one thing is we have to decrease the sensitivity at least 3 to 5 liters per minute flow sensor flow trigger, and we should eliminate the artifact, water in the tubes and air leaks, as well as we can change that trigger type, flow to pressure, because then patient needs a proper pressure drop rather than pressure flow turbulence. Patient needs a proper pressure drop to initiate the breath. So that is auto triggering. And the flow starvation. This can be seen a patient with high, especially in high respiratory drive. Suppose this is called air hunger. So in normal patient, pressure rises exponentially, but what happens when the patient has high respiratory drive and we set the inspiratory flow low, patient needs more, but ventilator doesn't provide, so that there is a dip in the pressure volume curve, pressure time curve. Okay, so what we can do is we can increase the inspirated flow to match the patient ventilator drive, or else we can suppress the we can treat the patient high respiratory drive. So that, for an example, we can treat the pain, okay, or else we can do sedation, or else we can treat the fever likewise. Okay, as well as we can, if we are in the volume control ventilation, we can switch into pressure control ventilation. That has minimal effect, this flow starvation. So that is flow starvation and the double triggering. So this is one of the common thing we see day to day. All right. So what happens here is there's a mismatch between the inspirated time of the machine and the patient inspirated time. So the mismatch means the machine inspirated time is shorter than the patient inspirated time. So this can be due to two reasons. One thing is we have set the machine inspirated time lesser. So if we have set the inspirated time I ratio and the respiratory rate in a way in a shorter period, or we have set the low tidal volume, so that will deliver this is quickly. But the patient, as well as this can be due to high respiratory drive, patient in high respiratory drive. So respiratory cycle ends, but patient efforts outlast the respiratory machine breaths. What happens that the continuous patient effort trigger another breath. Okay, that is called double trigger. The problem is the exhalation is not completed. So that therefore the second breath can cause increase in the volume and causing volume trauma. Okay, so so the problem is one thing is short ventilated machine breaths as well as high respiratory drive. So what we can do is we can increase the we can increase the respiratory time. So we can adjust the reduce the respiratory rate, or we can increase the tidal volume so that this phase will be more longer. As well as we can reduce the inspirated flow. Therefore, it will take more time to achieve this tidal volume. Or else we can, as I said earlier, we can suppress the high respiratory drive. We can use sedation, or we can use analgesics, or even paralysis the patient. Or else, as well as we can in pressure support ventilation, if the patient is breathing spontaneously, we can reduce the cycling threshold so that inspirated time ends early. So that is double triggering. So this is delayed cycling. I don't think we. All right. In any patient ventilator asynchrony, what we have to do first, we have to look at the patient. All right. So we have to check whether the patient is in distress or not, and then we analyze the waveforms and identify what is the type of asynchrony, whether it is a trigger asynchrony, flow asynchrony, or cyclic asynchrony. As well as we should identify the pathological or physiological derangement which can cause this thing. So like it can be acidosis, severe acidosis, sepsis, bronchospasm, whatever. Then we fix the things. So we set the ventilator settings that can be increased inspirated time, reduce the sensitivity triggers, and treat the cause, treat the fever, treat the sepsis, analgesia for pain, sedation for under-sedated patient, and paralyzed. And also, we can always incorporate the newer techniques and newer modes, like now our proportional assist ventilation, if it is available, which has better synchrony, which has better inputs from the patient. That is how we tackle the asynchrony. All right, coming into the latter part of the lecture, few things of graphs. So ventilator graphs can be scalars and loops. Scalar is a graphical demonstration of a variable over time. That can be volume time, pressure time, or flow time. Loop is a representation of a variable over another variable. That can be pressure volume or flow volume likewise. Okay. So there are many things we can, any information we can get from those things. Okay. So I'll highlight few things. This is not the whole thing. Few important graphs. One thing is flow time scalar. So as I said earlier, what we have to see whether this flow time curve reaches the baseline. Otherwise, there will be auto PEEP. So we have to ensure we have to adjust the ventilator setup in a way to increase the expirated time to achieve to touch the flow time curve, the baseline, before the next bed starts. Okay, this is one of the important thing you have to know. Other thing is the pressure volume loop. This is a very informative loop. So there are many things we can gain. So this is the pressure. When the pressure increases, initially there is a less compliant part in the lung, as in when we blow a balloon. And once this lower inflection point is reached, the lung is more compliant, and to a given volume, there's a more volume change. And once the lung is over distended, so for a given pressure volume, there is a minimal volume change. That is called over distended lung, which is called, this appearance is called beaking. This point is called upper inflection point. So one thing is we can get, so the steepness of this curve. So lower compliance, so less the flatter the curve, the flat, more less compliant the lung. So in ARDS patient, this would be like this. When the patient get better, this will gradually come into original place. Okay. Other thing is the lower inflection point. So this can be used to set the optimal PEEP. So this is one of the methods to set the optimal PEEP. So usually we calculate the lower inflection point by drawing the PV loop in the ventilator, and we set the PEEP usually 1 to 2 centimeter water above the lower inflection point, so that the ventilation will be operated in this part, more compliant part. And if there's a beaking, so we have to make sure to eliminate this part, so that we can to achieve that, we can reduce the tidal volume, as well as we can reduce the PEEP, so that there won't be no beaking, okay, because it can cause barotrauma. Okay, so that is few things we can get from the pressure volume loop. And the next thing, pressure flow volume loop. So this is the inspiratory phase, and this is the expiratory phase. So few things we can get. One thing is we can diagnose obstructive lung disease and restrictive lung disease here. So in obstructive lung disease, there is a dip in the expiratory phase, in expiratory obstruction. All right. In restrictive lung disease, the shape is same, but the volumes are minimal. Likewise. Okay. Restrictive lung disease. That is how we diagnose. We can diagnose lung diseases with flow volume curve. As well as if there's an air leak, this is the functional residual capacity, and this is the tidal volume. If there's an air leak, this expiratory limb doesn't come to a doesn't complete the loop. Rather, it come like this. So this volume is called the air leak. All right. Or else, if there's air trap in obstructive lung disease, this doesn't complete the loop. Rather, it can come like this. So this will be the that can demonstrate the air trapping. Okay, these are the few information we can get from the flow volume loop. All right. So this is few things regarding the basic stuff regarding ventilation. But keep in mind that when we ventilate a patient, not only ventilator strategies, but there are few things we have to think beyond the ventilator. So that can be prone positioning, especially in severe, moderate to severe ARDS, which will improve the ventilator perfusion mismatch, which has, very strong evidence for survival benefit, and early neuromuscular blockage, which will improve the patient ventilator synchrony, and dry lungs, so which will improve the lung compliance, as well as if available early ECMO, especially in severe ARDS patient, if the criteria meets. So those are the non-ventilatory strategies. So before winding up, this is now time for the questions.
Yes, Mihran. Actually, in the chat box, we have got a few questions. Actually, the first one was about, can you explain auto PEEP? I think you have already done it in several segments. And the next question is about ASV mode. Could you please explain about it, and also when to use ASV or intelligent ASV modes?
All right. So ASV is, can be specially seen in a Hamilton ventilator. So that is again a sort of advanced mode, so which has closed loop control. So if we see the ASV mode, I'll demonstrate. So it basically what we do, we wait. So we set the patient details, gender and the weight and the things, and we select the mode to AC. Okay, and what ventilator does, and we have to select the percentages of minute ventilation, whether it is 80% or 100% or 120%, and PEEP and the FiO2. And maximum pressure limit. All right. Likewise. So what the ventilator does, it would initially give a, control few breaths, and it will calculate the thing called plateau pressure and the expiratory time constant, so that they will decide an optimal respiratory rate for that patient. Like here, this is 16, and they will calculate a minute ventilation. So this is a minute ventilation, and this is the possible tidal volumes and respiratory rate that can achieve that targeted minute volume. So if the patient doesn't reach that tidal volume, that the patient will increase the pressures, or if the patient delivers more tidal volume, it will reduce the inflation pressures to match that target. All right. So that is basically we get the information from the patient. So that is sort of a pressure regulated volume control like. So anyway, but it's more complex than that, because they use the certain equations to get that optimal respiratory rate and the expiratory time constant. Okay, so so patient machine deliverer, the inflation pressures adjusted according to the patient response. The difference, so this is AC mode, is basically we can set set during for ventilation of any patient. But the problem is the minute tidal volume can go up. So especially when we ventilate ARDS patient, we have to closely monitor the tidal volume. So there are no evidence for AC in ARDS patient, because this tidal volume things, there are no studies basically. Therefore, that doesn't mean you can't use AC in ARDS patient, but you have to keep an eye on the tidal volumes. So that is one thing. All right.
Yeah.
In IntelliVent ASC, what happens? In addition to this ventilatory pressures and things, they get the information regarding the oxygenation as well from pulse oximeter. So depending on those values, depending on the set targets, they change the FiO2 and PEEP, so that to achieve that oxygenation target. So that has oxygenation part as well. So for AC mode, if we use, suppose we use AC mode for ARDS patient, if you see the high tidal volumes, you can gradually reduce the percentage of minute ventilation. Usually we use around 80 minute ventilation, or even in obstructive patient we use lower value. And patient with higher respiratory drive and metabolic condition like metabolic acidosis, we can go up to even 150 percentage of minute ventilation to match the compensation. So that is AC mode. That can be as a conventional respiratory mode, even as a weaning mode as well.
Right.
So
Yeah, Miran. So Miran, there was another question about SIMV mode, and the Dr. Lahirui, he's asking actually how to improve the volume delivery in SIMV mode.
SI mode, as I said, it is a synchronized mode. We have 3 types of breath. So one thing is we have to see. So I can't demonstrate here because the simulation is not supported for active patients. So let's see. So if the we have to see both things. I mean, assisted control as well as the supported breaths. So if the assisted breaths delivers a lesser volume, we have to increase this peak inspiratory pressure. So keeping in a safe limit. All right. If you see supported breaths are deliver less tidal volume, you have to increase this pressure support. So the top left hand corner, you can see the top pressure support. So we have to see both pressures to achieve balance not the balance actually, to achieve the set tidal volume is delivered in both phases. Did I answer the question, or do you need more clarifications?
Yeah, I think it was very quite clear, Mihiran. I think. Thank you. And also, there's another question about can you explain how to use pressure volume loop in ARDS patients? Yeah.
Yes, that is again. So we'll use pressure volume, right? So as I said, one thing is we can. This is the volume control. Okay. Actually, volume control mode. So one thing is, as I said, in ARDS patient, what happens? We can get many information. One thing is the lung compliance, and steeper the pressure volume loop, that is more compliant. So this is keep in mind, this is volume control ventilation. What happens in pressure control ventilation? Since the pressure is constant during pressure, that will take time, and pressure is like this and likewise. So anyway, we can assess the compliance of the curve. So initially in severe ARDS patient, the curve will be flat. So when the patient improves, when the lung improves, this compliance curve come to the original position, I mean to the leftward. That means more compliant. Other thing is the lower inflection point. So if I demonstrate this, so we should you can use this PV tool, pressure volume tool. So this is a bit advanced stuff. Okay. So we can set the settings and things. Don't worry about this. So we will start the manual. Okay.
Right.
And it will draw the pressure volume loop. And once the pressure volume loop is drawn, we can check the lower inflation point. Wait for that. So here it is not, this is just a simulation. We can check the lower inflation point and the upper inflation point, and we can adjust the PEEP accordingly. Suppose the low inflation point is here, we can check the compliance. Okay, so we increase the shift the cursor so that to achieve the improved compliance, so that we can set our PEEP 2 centimeters centimeter water above the low inflation point, as well as the upper inflation point. We can reduce the tidal volumes. All right. Anything else?
Yeah, Mihiran, and another question about prone position ventilation. One participant is asking how to overcome the hemodynamics disturbances or the compromisation that is happening with prone positioning. How to overcome?
Usually, prone positioning doesn't cause much hemodynamic instability because it is a preferable, I mean, position in terms of lung compliance as well as the hemodynamics.
Yeah, I
So
also agree with that because I mean, if you have a compromisation, what you do is you go with a central line and start on
yeah.
an and you are ready to escalate as needed. So, and ready with policies and all that. As you correctly, I think there's no disturbance because the oxygenation improves. So the hemodynamics become better actually, isn't it?
Yes, of course.
And another question, Miran, actually is another, in fact, the last question. So then one candidate asked, one participant asked, can we go down to FiO2 of 0.21 in an invasive ventilated patient? Can we go down to 0.21?
Usually it's not preferred. Usually we don't go beyond 25, but so you can just keep, so there's a risk of hyperoxia, but in those patients who needs lower FiO2, that means the lung pathology has already been resolved. So we generally we don't use FiO2 less than 25.
Yeah. Okay. And another question about prone positioning. One listener is asking Trendelenburg or reverse Trendelenburg, which one should we use with prone ventilation and how to decide?
Usually we keep patient flat. So the aim is to, the prone positioning is we ensure the more ventilated lung is in the non-dominant area. So if we increase, so preferably in supine, not the head down position.
Yeah, and also I think reverse Trendelenburg with 15 to 30 degree head up should be all right to prevent
Yeah,
aspiration, isn't it? Yeah.
that would be better. Yeah, definitely not the head down position.
Yes. Yeah. I think, Miran, that's about all the questions that we have got on the chat box. So I think it was quite a useful discussion. And since it is 10 o'clock, I think we can wind up, isn't it?
Yeah.
Yeah. Okay,
So
then.
anyway, so I don't think you can, I don't think you can go and practice ideal ventilation. Can you hear me? Hello? Can you hear me?
Yes, we can hear you.
So I don't think after this lecture you won't be,
Yes,
you'll be able to go and do the ventilation 100%. So this is just take this as eye opener. So I just briefed the thing, I gave an overview. So you should go and read, you can and practice, and day by day, you should improve your practice. So this is not I can't cover the ventilation with a 1 hour lecture. So anyway, I think you have got something from.
Yeah. So I think with that, we can conclude. So I will take this opportunity to thank Dr. Mihiran Herath on behalf of the college for taking up this lecture and doing it today. And I think it was very useful to everyone. And thank you, listeners, for being with us all this time. We were like 500 plus participants, and people were trying to come in, and they were quite disappointed also that they couldn't get a chance to listen. And so we'll hope to see you next time again with another interesting topic. And wish you all a very good night. And thank you.
Thank you very much.